Assalamu alaikum. Good evening, everyone. Today's session will be started by Dr. Nasser Al-Juhani. He's a consultant endocrinologist at King Fahd Medical City in Jeddah. He's a board member of the Saudi Society of Endocrinology and Metabolism and the ACE Gulf chapter. He's an editorial board member of many well-known journals. Dr. Juhani is a well-recognized figure who's always participated either as a speaker or an organizer in many meetings and workshops. Today's topic is an update on management of thyroid dysfunction in pregnancy. So without further ado, Dr. Nasser Al-Juhani, tfaddal.
Thank you very much, Dr. Khairia, for this nice introduction. You can share screen with us. Yeah. Today we'll talk about management of some common thyroid disorder in pregnancy. It is a tough topic. There is a lot of controversial, especially regarding subclinical hypothyroidism. I have nothing to disclose, and this is the agenda for the meeting. We'll talk briefly about 4 cases. Then we'll talk briefly about thyroid function testing in a pregnancy. Then the management of thyroid peroxidase positive thyroid women. Then we'll talk about subclinical and overt hypothyroidism, Graves' disease, and then briefly we'll give a touch about American Thyroid Association. Then we'll talk about what medication is safe during breastfeeding. Really, this recommendation from the American Thyroid Association, they recommend that all pregnant women 3 months before planning for pregnancy, they should ingest 250 microgram iodine per day. But unfortunately, many patients actually, they don't follow this recommendation. Many physicians, they don't follow up this recommendation. Even in countries with liberal iodized salt, they should have supplements as potassium iodide for all pregnant women, at least 150 mic per day. There is no need to initiate iodine supplementation if already the patient is hypothyroidism treated with thyroxine. Okay, no need. Or the patient has hyperthyroidism and get treatment. In this situation, don't give supplement. Otherwise, it is recommended to give iodine supplement in a pregnancy. This first case is a 25-year-old female. She is 11-week pregnant. She had mild nausea and heat intolerance. There is no medication except prenatal multivitamins. In physical examination, blood pressure is normal, pulse rate is normal. The patient is febrile. There is no tremor and no exophthalmos, no lid lag or lid retraction. There is mild thyroid fullness and normal tender reflexes. TSH is suppressed 0.08, 3 to 4 is normal, in the upper part of normal. So in this case, what you will do? You will start propylthiouracil, or you will start carbimazole, or you will repeat thyroid function in 4 weeks, or you request TSH receptor and thyroid peroxidase antibodies to rule out Graves' disease. So please vote for 15 seconds, please. So can the vote appear here? So to avoid delay. Yes.
We've got 54% said repeat TFTs in 4 weeks, and 42% said repeat TSH receptors and TPO antibodies.
So almost 50% equal between C and D. The correct answer is C. So repeat thyroid function for week. One reason, because subclinical hyperthyroidism. And usually subclinical hyperthyroidism is safe in a pregnancy to watch the patient and observe the patient. But make sure that you rule out secondary hypothyroidism. So this most likely HCG, human chorionic gonadotrophin associated transient thyrotoxicosis. If you can see from this graph that during the pregnancy there is increased estradiol. If you can see the green line here, the estradiol will increase the thyroxine binding globulin. So we'll see T3 and T4 will increase after 12 weeks and will be constant. So if you can see here, till the end of the pregnancy, there is increased T4 and T3, okay, because of the increase of thyroxine binding globulin. This is in the green. This the peak is. Will be human chorionic gonadotrophin secreted from the placenta. This will stimulate thyroid receptor. This stimulation of the thyroid receptor will increase production of free T4. This is in the red, free T4. At the same time, increased free T4 will suppress through the pituitary TSH. So in the first part or first 16 week of the pregnancy, you will find low TSH here, the green, and increased free T4. Very important, the fetal thyroid will depend in the mother in the first 16 week. So CNS development in the first 16 week of the pregnancy will depend in the mother thyroxine that crosses the placenta. After 16 week, it will depend partially in the fetal thyroid and the mother thyroid. The other thing, there is degradation of the T4 by the placenta. This will increase after 12 weeks. So you will need more thyroxine. In the pregnancy, you will increase 30 to 50% production of the thyroxine because of this demand. The other thing in the mother, because of the increased volume distribution, okay, there is increased iodine clearance through the kidney. So they will excrete the iodine through the urine. So for this reason, these lactating women and the pregnant women, they need thyroxine supplement. So this is a summary. TSH will decrease in the first trimester from 8 to 14 weeks. Then it will normalize for the rest of the pregnancy. The lower limit of TSH is 0.03 in the first and second trimester, and it is 0.013 in the third trimester. Free T4 has the opposite direction, may increase in the first trimester and then decrease approximately 20% in the second and third trimester, but usually within the normal range. But sometimes you can have Free T4 is low. So this is the old recommendation, 2011. This is old recommendation. They say that in the first trimester, you keep TSH from 0.1 to 2.5. Second trimester, you keep it from 0.2 to 3. And the third trimester, from 0.3 to 3. And this is depend in the publication of 6 studies that include 5,500 patients. But this recommendation actually in 2015 is changed. So in pregnancy now recommend that the upper limit of TSH is T4. This will include TSH level in normal ladies. This includes ladies with thyroid antibodies is negative and normal iodine status. So instead of the previous recommendation, the upper limit of TSH in pregnancy is 4 regarding patients they have antibodies. So this is the TSH in pregnancy from 0.1 to 4. So PT4, as we said, may be falsely low. We know that because of the thyroxine binding globulin increase in the pregnancy, this will bind to thyroxine. So the free T4 may low because we know that free T4 represent only 0.05% of the total thyroxine. So maybe falsely low. So if you suspect that the assay is false, you can check T4 and T3 and you multiply it by 1.5 in the second and third trimester. So TSH during pregnancy is from 0.1 to 2.5, no further workup. TSH from 2.5 to 10, check antithyroid peroxidase antibodies. If TSH more than 10, no need to check antithyroid antibodies because you will treat immediately. The second case, 28-year-old female, Gravidarum para 1, 6-week pregnant, has or had type 1 diabetes, well controlled. TSH is normal, 2.3, and PT4 is normal, and antithyroid peroxidase antibodies is positive. So this is a case of thyroid peroxidase antibodies positive, type 1 diabetes, TSH 2.3. So what's the most appropriate action in this lady? Do you will add thyroxine, or you will add steroid, or you will add immunoglobulin, or just repeat thyroid TSH in 4 weeks? So vote for 15 seconds, please. So Dr. Khairia, any response?
Yes. Most of the voting said 60% said repeat TSH in 4 weeks. 5% said add immunoglobulins, and 30% said add L-thyroxine.
Excellent. So the majority, they are right, actually. So we'll repeat TSH. But really, some people, they treat. Some people, they use prednisolone 5 milligram per day in the first trimester, because there are some studies, but this is not enough to recommend it, actually. So in patient with if the patient has antibodies is positive, but thyroid, actually they have at risk of abortion. So actually the risk of abortion in these patients, even if they are euthyroid, if they have normal thyroid function, is increased almost fourfold. Preterm delivery also increased twofold. And this patient, if they have antibodies during pregnancy, they are at higher risk for postpartum thyroiditis. So even if they are euthyroid, but there is no sufficient evidence to recommend the treatment. So maybe you treat or maybe you don't treat. So this is kept for the discretion of the physician. So this study published in New England Journal of Medicine in April 2019, they look for these patients. They bring, it is RCT trial, they look for TBO positive euthyroid women before pregnancy. TSH was from 0.4 to 3.6. They have in each arm almost 470 patients. They give them 50 thyroxine and the other is placebo. They found there is no difference, actually. Regarding the pregnancy outcome, there is no difference. So they conclude from this study that the use of thyroxine in a euthyroid woman with thyroid peroxidase antibodies does not result in higher rate of live birth than placebo. So what we do if we have patient already positive antibodies? We do the antibodies, we should check TSH every 4 weeks in the first trimester, and then we check it again in the second and another time in the third trimester. Because some patients with antibodies positive, they can develop subclinical or clinical hypothyroidism. So what's the recommendation, American Thyroid Association recommendation regarding the treatment of subclinical and clinical hypothyroidism in a pregnancy? They said if TBO positive and TSH more than 4, you treat. So if you have antibodies is positive, antithyroid peroxidase antibodies, and TSH more than 4, you treat strong recommendation. If the antibodies is positive and TSH from 2.5 to 4, you may treat or you may don't treat. So consider treatment. So this is weak recommendation. It is clearly if the antibody is positive and TSH more than 4, you should treat. It is between 2.5 to 4 is not clear. So you can treat or maybe you don't treat. What's about if the antibodies is negative? If the antibodies is negative and TSH in pregnancy is less than 4, no treatment. So this is a strong recommendation. In the past, actually, we treat 2.5, we treat them if they're above 2.5. If the antibody is negative and TSH from 4 to 10, you may consider treatment. It is weak recommendation, but it is clearly if TSH more than 10, you should treat. So in summary, if the antibodies is positive and TSH more than 2.5, you treat. If the antibodies is negative and TSH more than 4, you treat. There is one exception to this rule. If the patient undergoing IVF or in vitro fertilization technique or ICSI, you should treat. You should keep TSH in this patient regardless of the antibodies below 2.5. This is the exception to the rule of the patient going to IVF that you keep TSH less than 2.5. So what's the dose if the patient has hypothyroidism before pregnancy? What's the dose? Usually we add 2 extra doses, okay? So we add 2 extra doses, or you add 25 mic daily to the previous regimen. The aim is to keep TSH from 1 to 2.5. And be careful that you return to the previous dose after pregnancy and you repeat the test again, okay, after pregnancy. Because after delivery, you should check again the TSH level at 6 weeks. And during pregnancy, you check TSH every month for the first half of the pregnancy. Then at least you check it once again at 30 weeks. What you have newly diagnosed during the pregnancy? If already has offered hypothyroidism, use thyroxine 1.6 microgram per kg. If you have subclinical hypothyroidism and TSH less than 10, you can use 1 mic per kg. If the SH between 2.6 and 4, you can start empirically 50 mic. And the aim is to keep the SH less than 2.5. What's about Gravis? Sometimes Gravis is very difficult to differentiate from hyperemesis gravidarum. But if there is no vomiting, usually in hyperemesis gravidarum, usually happen in the first trimester, and usually they have repeated vomiting, they have nausea, and they have weight reduction. So if you don't have vomiting, if you have a previous thyroid disease before the pregnancy, or if you have thyroid bruit, or ophthalmopathy, or if you have muscle weakness, or if the pulse rate more than 100, this is suggests Graves' disease rather than hyperemesis gravidarum. And the other thing, usually TSH will be very low in Graves' disease, and 3 to 4 will be clearly high. But usually in hyperemesis gravidarum, in many cases, you will find the 3 to 4 is minimally elevated, and usually T3 is not elevated in hyperemesis gravidarum. This is another clue to the diagnosis. Also, sometimes very difficult to differentiate between the two, and you request TSH receptor antibodies. But be careful. Still, in 20% of the patient with Graves' disease, TSH receptor antibodies can be negative. 80% they will have positive antibodies. So, regarding the Graves' disease in a pregnancy, 85% it is related to Graves' disease. And in the first trimester, there is exacerbation, like most of the autoimmune disease. In the second half of the pregnancy, there is immunosuppression. So immunosuppression, the antibody titer will be decreased, and there is actually remission of Graves' disease. Like other autoimmune disease, like rheumatoid arthritis, SLE also remit after the second half of the pregnancy. In the postpartum period, it is the same like the first trimester. There is maybe rebound, and there is aggravation of the Graves' disease. This is the side effect or the complications of thyrotoxicosis maternal. You can have stillbirth, preterm labor, preeclampsia, congestive heart failure. In severe thyrotoxicosis, you can have thyroid storm. Fetal, you can have small for gestational age, fetal tachycardia, hydroburst fetalis, and neonatal thyrotoxicosis. The third case is a 28-year female, 6-week pregnant, known case of Graves' disease in carbimazole 10 milligram for the past 8 months. Usually in Graves' disease, we continue antithyroid medication for 1 year to 1.5 years. Usually I continue it for 1.5 years. Heart rate is normal, blood pressure is normal, no goiter, no bro. TSH is 0.3, 3 to 4 is 1.6 is normal. Thyroid receptor antibodies or thyroid stimulating immunoglobulin is undetectable in this case. So what's the action you will do? Do you replace with propyl theracin? Do you continue carbimazole? Or you decrease the dose of carbimazole? Or you stop carbimazole? Please vote. Dr. Khairia, any vote?
Yes, so we have 52% replaced with PTU. 19% said continue carbimazole, 16% decrease the dose, and 12% stop carbimazole.
Okay, so 12% this time is right, actually. Stop carbimazole. Welcome for that. So in this case, already 8 months pregnant, and she has a Graves' disease since 8 months. When to stop carbimazole in pregnancy? The recommendation, the maximum teratogenicity is during 6 to 10 weeks of pregnancy. So in a newly pregnant lady with Graves' disease, who is euthyroid like this patient, in low dose of methimazole like this patient, 5 to 10, or propyl theracin less than 200, the physician should consider discontinuing all medication given potential teratogenic effect. So when we stop, this is weak recommendation actually. So rarely you can have congenital malformation associated with carbimazole. The commonest is a scalp defect. You see here there is loss of the skin here called aplasia cutis. Sometimes you have choanal atresia, tracheoesophageal atresia, patent fetal intestinal duct, you have PSD, or you have dysmorphic facies. This is rare, happily. from 3 to 4%. يعني double. In a pregnancy, maybe 1 to 2%. In this cases, can be 3 to 4% of the cases. So almost increase 100%. Also, there is congenital malformation with the probile thyroid. What's the difference? This happens in 2 to 3% and usually milder. For example, you can have periauricular sinus like this here, sinus. You can have urinary tract abnormality like kidney cyst or hydronephrosis. So if you can stop it better. So when you stop it, first, if the treatment duration more than 6 months, if the pre-pregnancy TSH is normal, if carbimazole dose less than 15 milligram per day, if methimazole dose less than 10, if the thyroid receptor antibodies is normal or slightly elevated, if there is no goiter, no active ophthalmopathy. So if you have all these features, you can stop and closely you observe the patient. You should monitor TSH 84 anti-3 every 4 weeks. So what you will do if you stop? So in first trimester, 16 week, usually will replace by the probile thiorasol, less crossing the placenta. Both can cross the placenta, but the effect is less. So in the first trimester, prefer the probile thiorasol. In the second trimester and third, you can use either probile thiorasol, methimazole, or carbimazole. Block replacement and iodine is contraindicated. Block replacement, they use carbimazole, for example, with thyroxine. It's contraindicated in pregnancy. How to change dose from methimazole? You multiply by 50. For example, if methimazole dose is 10, you multiply by 20, so 20 is 200. So 20 by 10 is 200, so we'll give 100 BID. The carbimazole dose is 40% higher than the active methimazole. For example, 10 milligram carbimazole equal to 6 milligram methimazole. So usually you keep free T4 in the high normal range. If free T4 is unreliable in pregnancy, okay, you can use total T4 and total T3, and you keep TSH. Usually don't normalize to SH. You can keep it from 0.1 to 0.3, because if you go higher, make TSH higher than this range, above 0.3, probably you induce fetal hypothyroidism. And very important to monitor free T4, free T3, and TSH every 2 to 4 weeks at the pregnancy and adjust the dose. At the end of the pregnancy, yani third trimester, sometimes you can stop antithyroid medication, but be careful. If the anti-TSH receptor antibodies is high, the titer, don't stop it, okay? So sometimes you can reduce the dose or stop actually in the at the end of the third trimester, you can stop antithyroid medication. So the most important step is to monitor TSH, T3, so you can adjust your dose up and down. Case 4, this is the last case, a 30-year-old female, 12-week pregnant, a case of Graves' disease, treated with radioactive iodine since 2 years. She's in hypothyroid due to radioactive iodine. She's now in L-thyroxine 150 mic once daily. TSH is normal, free T4 is normal. So do you recommend testing for TSH receptor antibodies in this lady, yes or no? So who will say yes? Who will say no? Please vote. She's pregnant. She has a Graves' disease, treated with radioactive iodine 2 years back. She's in thyroxine 150. She is a thyroid. So do you monitor TSH receptor in the serum or not?
You have a couple of minutes left, Dr. Nasser.
Okay, thank you. So they can vote yes or no. Who will recommend will do testing? Who will not recommend?
So the majority, 67% said yes and 37% said no.
Yeah, excellent. But really in clinical practice, we don't use T4 in clinical practice. We don't use really in clinical practice pregnancy reference range. I don't think is it available in most of the hospital pregnancy reference range for TSH, pregnancy reference range for free T4. So probably it's not available like this. It is not easy, probably available in much hospital. But really, they are right. We should monitor it. Any patient with Graves' disease, we should monitor. When will come for this? So when we need to check it, we need to check it if the patient has active Graves' disease, either in antithyroid medication or off, recently discovered. You should check anti-TSH receptor antibodies. Any patient with past history of Graves' disease treated with radioactive iodine or surgery, ideally the recommendation, they recommend that we should monitor it. Past pregnancy history with fetus with thyroid dysfunction. Not all people with antibodies positive, it will cross the placenta, almost in 5% of the cases. So still in about 90% of the cases, even if the antibodies is positive, it will not harm the fetus, but it is recommended that you measure it. So when you should measure it, first when the patient presents for us in the clinic, we measure it. If the TSH receptor antibodies or thyroid stimulating immunoglobulin is normal or low, no need to monitor it again. Just stop monitoring. But if you find it high, you repeat the test again at 20 weeks, plus minus 2, of course. If it is high, especially threefold, the significant antibody titer is increased threefold compared to the normal range. So you need a close fetal monitoring. We'll come how we monitor this. If it is high at 20 weeks, you should monitor again at 32 weeks because need a close fetal and neonatal monitoring. What you will do, this is the risk. If the antibodies is a threefold higher than normal, there is the risk of fetal hyperthyroidism is increased. So how monitor for it? Usually they do fetal ultrasound at 22 weeks, and they repeat it again at 32 weeks, and they repeat it again at 36 weeks. And they check the fetal heart rate. If it is more than 170 beats per minute, you should suspect fetal hyperthyroidism. If there is acceleration of the growth or there is fetal goiter, you should suspect either fetal hypothyroidism or hypothyroidism. This is the last two slides. Thyrotoxicosis and lactation generally safe. The lowest dose, we should use the lowest dose of methimazole or carbimazole or propylthiouracil. We should use the lowest dose. Propylthiouracil less than 300, or some they write even below 450. Even methimazole below 20 is safe during pregnancy, and usually no need to monitor the neonatal. You do neonatal test for thyroid function. Carbimazole below 20 is safe, even up to 30. Up to 30, you can use carbimazole in lactation. So usually, if you use higher dose than this, you may monitor thyroid function test. Very important that breastfeeding, they have supplement as multivitamins of iodine. This is available outside in multivitamin. At least they use 150 microgram per day. Radioactive iodine 133, 131 is contraindicated during lactation. You can do, if indicated, sometimes you have postpartum thyroiditis. You don't know, is it really postpartum thyroiditis or is it Graves' disease? If the TSH receptor antibodies facility is not available in your institute, you can do radioactive iodine 123, and you should discard the milk. You pump the milk and discard it for 4 days after you do this scan, because you are afraid that it will go to the milk and will be absorbed by the fetus and affect the thyroid fetus. So if it's strongly indicated, you can do it. If it's not strongly indicated, better to avoid it. Technetium, easily you can use it, and you pump the milk at the same day. So if you face difficulties in differentiating postpartum thyroiditis, because we know the postpartum thyroiditis, the treatment is symptomatic. In a Graves' disease, you need to give medication. You can do technetium, and you can pump the milk and discard it in the day of the testing. So this is the last two slides. In summary, previously recommended TSH cutoff of 2.5 to 3 are low and may lead to overdiagnosis and overtreatment. Insufficient evidence exists to determine whether LT4 therapy decreases pregnancy loss and preterm delivery risk in TPO positive euthyroid women. It checked thyroid peroxidase antibodies in all pregnant women with TSH from 2.5 to 10. No treatment if TSH is less than 4 and thyroid peroxidase antibodies is negative. May consider treatment if TSH more than 2.5 and thyroid peroxidase antibodies is positive. More data is needed to assess thyroid peroxidase positive people with TSH between 2.5 to 4 and thyroid peroxidase negative and TSH from 4 to 10. Preconceptual optimization of maternal hypothyroidism and Gravidarum is very important. Counseling needed for all childbearing ladies. We should inform them that very important to control hypo or hyperthyroidism before they get pregnant. Sometimes you can refer them for OB-GYN for pregnancy control. Maternal hypothyroidism can be determined until to the fetal development, if not corrected very early pregnancy at the time of a pregnancy confirmation. Preconception control of preconception control of use of antithyroid in the first trimester is associated with increased risk of fetal anomalies and should be avoided if possible. Regarding, this is the slide from the company, they asked me to present it. Regarding the protocol of management of hypothyroidism, consensus of Gulf countries, this is published by the main publisher, Dr. Ali Zahrani, in his colleague, regarding the diagnosis and management of hypothyroidism. In Gulf countries, it is available in advanced therapy. You can everybody look for this, the recommendation, when to treat, when to screen, what's the treatment. This is very important to look for it. Also, in the Apple Store or the Google Play, you can download the check. It is called Merck Check. This application really will help you regarding the dosing recommendation for different patient population. So if you upload this from Apple Store or the other applications, will help you to look for the international guidelines. So it is available in this, and also how to calculate the dose according to the age, according to the gender, and according to the weight. Thank you very much, and sorry for today.
Thank you, Dr. Nasser, for this very interesting coverage. We're going to leave the questions at the end. We will now go to the second speaker, Dr. Adnan Al-Sheikh. He's a consultant pediatric endocrinologist at King Abdulaziz Medical City, Jeddah. He's an associate professor of pediatrics at King Saud bin Abdulaziz University, an associate dean, College of Medicine at King Saud University in Jeddah. He has many publications in the field of pediatric endocrinology, and he's going to talk to us today about thyroid disorders in children. So, Dr. Adnan, please go ahead.
Assalamu alaikum wa rahmatullah.
Alaikum assalam.
I'd like to thank you, Dr. Khairia, for the introduction, and I'd like to thank the organizing committee for giving me the invitation and giving me the chance to talk about thyroid disorders in children. So my topic is thyroid disorders in children, and the organizer asked me to, organizing committee asked me to talk about cases, to put cases and discuss it. And I thought the best is to choose something related to the topic of my friend Dr. Nasser Al-Jahani, the first speaker. So let me start the first case. So I'll present two cases with the discussion after each case. So this is, we received a consultation from the NICU to see a one-day-old baby girl because of jitterness and irritability and tachycardia and query goiter. And she was a premature 34 weeks gestation, and the birth weight was 1.9. There was a clue from the history. Mother was a known case of Graves' disease, and she was on treatment for about 1 year on PTU. uh, with follow-up in adult endocrine in another hospital. And she had a regular follow-up in the first trimester there. Antenatal ultrasound showed fetal goiter and polyhydramnios. So at birth, the baby developed cyanosis, mild cyanosis, needed nasal CPAP, and then shifted to ventilator for about 1 week. Chest X-ray showed borderline cardiomegaly, query, congestive heart failure. When we saw the baby, he was irritable, had jitterness, anxious baby. The heart rate was around 160 to 170. There was a goiter, and I will show you the slides of the baby. And the eyes were prominent, so query or slight exophthalmos. And there was no evidence of congestive heart failure. Otherwise, the baby was normal. So on the first day of life, uh, uh, these are the symptoms. So based on the family history, we started beta blocker, propranolol, and we draw the samples for thyroid function test. And the results came the end of the day, and it showed that the TSH is very suppressed in the baby, and the fetal thyroid, the free thyroxine level was high. Just to remind you that we, in our hospital, we are using the picomole, and the normal range is 10 to 20. That is different from the reference ranges used by the first speaker. So the results of free thyroxine level is significantly high. So that confirmed the diagnosis of neonatal thyrotoxicosis, and we started the baby on BTU, 10 milligram per kg per day. And on day 6, we repeated thyroid function test, and actually it was a surprise to us because the free T4 level was even higher. It reached to 32. Remind you, the normal range is 10 to 20, so almost 1.5 the normal range. So we increased the dose of BTU. This is the slide of the baby. He was really anxious baby, restless, and significantly tachycardic, irritable. I'm not sure if you can see, I tried to do the picture. You can see that he got a prominent thyroid glands, and maybe this slide will show that he got really goiter, and also prominent eyes. You can see that. So we continued the treatment, and then we followed thyroid function every week, and he responded. The free thyroxine level decreased up to 8 over the next 4 weeks. But the free T3 was still slightly in the higher side initially. And at this stage, at 5 weeks, we got the results of the TSH receptor antibodies. As Dr. Nasser mentioned initially, we have to do the TSH receptor antibodies either on the baby or on the mother for any patient or any pregnant lady with Graves' disease. So we did this TSI or TSH receptors on the baby, and the results came after about maybe on the 5 weeks, and it was very, very high. It should be really unmeasurable, or less than 2, and it is 54. So that is very pathognomonic that this baby has a neonatal Graves' disease or a neonatal thyrotoxicosis. We decreased when we saw the free thyroxine level on the lower side, we decreased the BTU dose, and look what happened. So on the 7th week of age, his free thyroxine level increased again. So we have to go up a little bit with the dose of the PTU, and over the next few months, we decreased the dose and we stopped the PTU, at the age of 6 months. So his disease or neonatal Graves disease resolved at the age of 6 months. And we followed this baby and over at 9 months and at 1 year, and she's completely normal, resolved clinically and biochemically from this neonatal Graves disease. This is her picture at 1 year of age. To my surprise, the mother came during follow-up after about maybe 1 year with a thyroidectomy to treat Graves disease. She was treated in another hospital outside Jeddah. I think maybe radioactive iodine was not available, or maybe she refused it. I have no idea. So maybe Dr. Nasser can comment on that during the discussion. So just a few slides on the neonatal thyrotoxicosis. It's really rare disease. It occurs in about 1 to 5% of infants born to mother with Graves disease. But the Graves disease itself in pregnancy is very, very rare. It's about 1 in 4 or each 1,000 pregnancy. We know that the thyroid gland and embryologically develop at the base or originate at the base of the tongue and then descend gradually until it reaches its final destination in the neck by about 7th week. And then very interesting that the thyroid gland start to make or to synthesize thyroid hormone at about 12 to 14 weeks. This is maybe a common question for the fellows and maybe resident in the exams. So what crossed the placenta during pregnancy? What crossed from the mother to the baby? Anti-thyroid medication can cross the placenta easily, both the BTU and the methimazole. And maternal thyroxine cross the placenta, but in very, very small amounts. And the evidence for that is the babies with athyrosis. When we say athyrosis, meaning that the baby has no thyroid gland, when they are born at birth, they have a normal, usually they got a measurable thyroxine level up to 8 or maybe 10 or 7 becomol. So what is the source of this thyroxine? It has to come from the mother. So this is really the evidence. In the past, we usually say, or in the past, we used to say that thyroxine does not cross the placenta, but this is a very strong evidence that it crossed, but in small amount. Now, TSH receptor antibodies, either stimulating or blocking, freely cross the placenta to the baby. And but other antibodies like Hashimoto antibodies, it can cross the placenta, but there is really no evidence that it can cause a major or minor effect. There is a report that it causes significant increments of abortions. So neonatal hyperthyroidism occur in 2 forms. Either it is autoimmune, that is due to or secondary to maternal Graves disease because of the transplacental passage of the TSH receptor stimulating antibodies. As we mentioned, it can cross freely from the mother to the baby even after many, many years of resolving the disease in the mother. I got another case. The mother was treated 7 years back by radioactive iodine, and she delivered a baby who developed neonatal Graves disease. So even even inactive Graves disease mothers, you have really to get a good history and to screen the baby for the TSI or TSH receptor antibody. The other rare cause of neonatal hyperthyroidism is non-autoimmune, or it's actually caused by activating mutation of the TSH receptor and the fetus himself. This is really rare, but it is autosomal dominant, and we saw a few cases in Saudi Arabia. How they present? In the fetus, they will present with fetal tachycardia, and the baby will develop intrauterine growth retardation or maybe premature delivery. If not treated or not picked early, the baby can develop craniosynostosis with a frontal bossing, and he could die because of congestive heart failure and hydrops fetalis, and the mortality rate is about 16%. So to avoid this consequence, any pregnant lady with a history of maybe Graves' disease, even many years back, you should really check the TSH receptor antibodies. The clinical presentation in the neonate, usually they present in the first 2 days of life, but it could be delayed up to 10 days of life, and they are usually IUGR, and they have goiter, which is picked sometimes by the fetal ultrasound or at birth. They are very irritable like our baby, and jittery and restless, and they could have periorbital edema and or exophthalmos, and they could have cardiac failure and or tachycardia. And the diagnosis is very easy in a baby with a positive mother or with a Graves' disease. You check thyroid function and you find very high free T4 and suppressed TSH. And of course, you will check the TSI titer in the mother. And so if you got any baby with high free T4, go and check the mother thyroid function and also measure her TSH receptor antibodies. So this is a strong recommendation as mentioned by Dr. Nasser. The treatment, we start with the beta blocker, and then we add BTU. Initially, it was our first choice until 2010 when there was an FDA warning because of fatal cases due to acute hepatic failure from the BTU. So it is now contraindicated to be used in children in general, and of course in neonate. But at that time, it was that case was before 2010, so it was our first choice, so we started it. And the second choice at that time is methimazole, which is now the first choice. Actually, the BTU has a better advantage because it also inhibit the conversion of free T4 to free T3. In the beginning, if there is signs, symptoms of severe thyrotoxicosis in the baby, you can start Logol solution, which is a potassium iodide. Usually, you'll start with 1 to 3 drops Q8 hourly, and usually the babies will need it in the first maybe 5 days to 1 week. So the conclusion of this case, neonatal thyrotoxicosis is really serious. Fortunately, it is rare, and unfortunately, it is self-limited and transient disease. Usually, it disappears, and the disease resolves by most in 6 months, like our case. And also, my second patient also it resolved at around the age of 4 to 5 months. The mortality is really high in those babies, up to 15% if the baby was not diagnosed early and not treated properly. So let me move to the second case, which is also related to the pregnancy. So this is a 2 days old baby. The mother, he was a term baby, no need for NICU admission at that time. The mother is gravida. She was previously healthy except for gestational diabetes on diet. And there is really negative family history of any disease. And there is no consanguinity for the parents. On examination, the baby was completely free and completely asymptomatic. So you wonder why we came to see the baby. Actually, we came to see the baby because the cord blood results, the neonatal TSH in the cord blood was high, was 191. So we requested the lab to do the free T4, and it was borderline low. As we mentioned, it's between the normal range between 10 to 20, so it was about it. So we requested to repeat, that was cord blood sample. So we repeated we called the family, and we repeated the thyroid function test on the second day, and the TSH was very high, 212, and the free T4 was 8. So that, yeah, so we did a nuclear thyroid scan urgently. We did it actually on the third day, and it showed an increased thyroid uptake significantly, and it showed that the thyroid is present in situ, in place, and it showed increased uptake. We did it by the technetium 99, and that is suggestive of, I think it's very maybe obvious to most of you, that this is a congenital hypothyroidism due to dyshormonogenesis. So this is the diagnosis in this case. So just a few slides about congenital hypothyroidism. It is the most common preventable cause of mental retardation in children. The incidence worldwide is about 1 in 4,000, but in Saudi Arabia it is really more common than the international incidence. It's 1 in 2,500. Usually those babies were diagnosed by the neonatal screening program for TSH. And the major benefit of this screening program is really to pick those babies, diagnose them because they are asymptomatic, and treat them to prevent mental retardation. So what are the causes of congenital hypothyroidism on those babies? The first cause is thyroid agenesis, or what we call athyrosis, meaning no thyroid gland, or it could be dysgenesis, meaning that the thyroid is there, but it is malformed and small in size, and this is usually sporadic, or it could be ectopic. And if you remember the previous slide in the development of the thyroid gland, we know that the thyroid gland in the fetus develop and originate from base of the tongue. So if it failed to descend, then it will be an ectopic thyroid gland, or ectopic congenital hypothyroidism, and this is also sporadic. Now, our case has dyshormonogenesis, which is an enzyme defect in thyroid synthesis, and this is an autosomal recessive defect in one of the enzymes responsible for thyroid synthesis. And this is actually, and I will show you our data, that it is actually common in Saudi Arabia. Now let me show you this girl who had very interesting, what you can see, this is a girl who had an ectopic thyroid gland. Can you see at the back of the tongue, or at the base of the tongue, a swelling? You can see this swelling. The father actually helped us a lot to ask to lean to show us the gland itself. Can you see? So this is actually the ectopic thyroid gland, and it is lingual. Very interesting. Other causes of congenital hypothyroidism, of course, is central hypothyroidism, and usually those babies will have other congenital malformations like syndromics, or maybe midline defects. Rarely it could be isolated, or it could be part of actually panhypopituitarism. Also, rarely you can see thyroid hormone resistance, which is an autosomal dominant cases. We have very few cases with that, and sometimes you were called to see babies with a high TSH with a cord blood, and you'll find that they got a transient hypothyroidism. So now let me tell you about our neonatal TSH screening program. This is we are proud in Saudi Arabia that we have this neonatal TSH program. It's actually started since 1975. There was some hiccup in doing this or applying this program, but I will tell you maybe in the last 15 years, it's really, or 20 years, it's really applied very well. Basically or simply, we do a cord blood TSH for every baby born in Saudi Arabia. In the private hospital, government hospital, in any city in Saudi Arabia, they will have a cord blood done for the baby, and we know that cord blood reflect the baby blood, and if it is less than 30, then this is normal. Nobody will call you, and the baby is normal. This is the normal range and cord blood for the TSH. And if it is between 30 to 60, this is a borderline. So the lab will call us, either the central lab or the lab in your hospital will call you. So we ask them to do the free T4 in the cord blood itself. If it is low, then we will call the family to do thyroid function test from the baby blood. If it is normal, then we will book them in 1 week or 2 weeks in the clinic to repeat, just to be sure that they are in the transient group. And then if the TSH is more than 60, the neonatal TSH or the cord blood TSH, this is really emergency. This is really an urgent. This is completely abnormal. So we ask the lab to do the free T4 in the cord blood sample itself, and we call the family to come and repeat thyroid function test from the baby himself. And of course, we try to plan a nuclear thyroid scan quickly, maybe in the first 2 days, if possible 3 days. And if not, then we really start thyroxine treatment as soon as possible. So we are really proud that we have this system, the National Neonatal Screening Program, applied in our country, and it's really done very well. In most of, actually, I will go back to this slide. In most of the world, they do this program, the TSH screening program, except in the state, they do a free T4 screening program. In Aramco, where our colleagues, Dr. Abdul Jabbar work there, they do the free T4, the screening program. But in all the countries in Saudi Arabia, we do the neonatal TSH screening program. So the aim or the is really to treat as early as possible. We usually start with 10 to 15 mic per kg per day of thyroxine. Usually they will need between 25 to 50, and then you titrate the dose to keep the free T4 in the upper half of normal and the TSH suppressed less than 10. And of course, clinically and biochemically, they should be euthyroid with a normal growth. I will just maybe just give you 2 minutes or 3 minutes comment.
2 minutes remaining.
Okay, this is a study we did to see what is the trend of congenital hypothyroidism Saudi population. This in 2 large tertiary center between us in Jeddah and Riyadh. Our colleagues, Prof. Ibrahim Al-Alwan and Amir Babikir and Dr. Arij Sufyani and myself, to see, this is about 18 years of experience to see how common is congenital hypothyroidism in Saudi population. So we found about 71 babies. 80% of them were diagnosed in the first week of life. And the estimated incidence based on the rate of delivery in these 2 hospitals was actually common, 1 in 2,500, and 43% were ectopic thyroid, like the patient I showed you, too lean, and about 34% has dysharmonogenesis, like our case presentation, and thyroid agenesis or hypoplasia was only 22%. Learning difficulties were actually associated with the late treatment onset or with the poor compliance with treatment. So I will show you that actually 80% of our patients were diagnosed and treated in the first week of gestation of age, and about 7% on the between the first and 4 weeks. And actually those who were diagnosed after 1 month, most of them were central hypothyroidism, where the neonatal TSH screening program will not pick them. And actually 92% of our patients had primary hypothyroidism and 8% were central hypothyroidism. And we found that positive family history were 26%, and 33% were had a consanguinity. According to the rate of consanguinity, marriages in our Saudi population, according to the report from our metabolic colleagues like Dr. Majid Al-Fadl and other groups, like the rate of consanguinity is 50%, 50 to 55% consanguinity in marriages. So as I mentioned, 34% were dysharmonogenesis, and most of those with the primary hypothyroidism were diagnosed on the first week, and actually most of those were diagnosed late were actually central hypothyroidism. And just to show you that actually those who developed learning difficulties, they were either not compliant with the treatment, or they were diagnosed later after than 1 month with a significant p-value. And also those who had a school performance, they had actually poor compliance with the treatment. So the conclusion from our study that early management of early diagnosis and management of congenital hypothyroidism is essential to avoid long-term neurocognitive damages. And in consanguineous population, like our Saudi population, the incidence of dysharmonogenesis is high, 34% compared to the international rate of dysharmonogenesis, which is about 15%. So we got actually double the incidence of dysharmonogenesis compared to international rate. And effective neonatal screening program facilitate early diagnosis and treatment of congenital hypothyroidism. With that, I would like to thank you for your attention.
Thank you, Dr. Adnan, for this very interesting topic coverage. We will now take questions. We'll start with Dr. Jihani. There's a couple of questions for Dr. Jihani.
Yes.
The first question is, if a pregnant patient who has hypothyroidism on thyroxine, and as you suggested in your talk, we increase the dose by 2 doses more per week in early pregnancy. The question is, should we go back to the normal doses? Should we go back to the normal doses at the end of the first trimester?
No. We double 2 days. For example, if she take before pregnancy 100 microgram per day, we need to double the dose for 2 days, يعني 200. So 200, you will divide it for 7 days. For example, and for example, if she take 100 mic before pregnancy and get pregnant, 2 days they will double the dose. Either they take 200 for 2 days per week, and immediately they check TSH and the FT4.
Yes, the question is, with this increase, should she continue only for the first trimester or until the end of pregnancy?
End of pregnancy and after delivery, you should check and you go to the pre-pregnancy dose. So all the pregnancy, of course, you will check TSH every 1 month for the first half of the pregnancy. Then at least once in the second trimester, then once at the third trimester. So in the first trimester, actually, you check the thyroid function TSH every 1 month. So at the end of the pregnancy.
Okay. Okay, the second question is, if a female who is pregnant and doesn't know that she has thyroid disease and did not take any treatment for thyroid disease, is there any harm for the unborn child?
Yeah, of course, depends. Is it any frank, for example, hypothyroidism or not a frank? Universal screening is not recommended. Yani to screen all the people for thyroid, but in practice, really, we screen for all ladies. This is what happens in clinical practice. We screen for all the ladies in the pregnancy. But you screen for patient with family history of thyroid disease, patient with goiter, patient with symptoms, patient, for example, with miscarriage or abortions, patient with preterm delivery, but universal screening not recommended. But of course, there is harm. There is a frank hypothyroidism, even subclinical hypothyroidism. There is risk of abortion. There is risk of preterm delivery, in neurological development delay approved in frank hypothyroidism and offered hypothyroidism mainly. In subclinical hypothyroidism, there is inconclusive data that show that it will affect the brain of the fetus. So of course will affect if it is frank hypothyroidism mainly.
Okay, thank you. There's a third question that is coming in. Actually, it's for Dr. Nasser also. How to follow a patient with hyperthyroidism after radioactive iodine? And should we continue with methimazole? And when should we repeat the thyroid function after radioactive iodine?
This is not pregnant?
It
not pregnant, okay. Yeah. Regarding usually the efficacy of radioactive iodine, I am talking about of course non-pregnant lady. Pregnant lady will not give radioactive iodine because it will cross the placenta and the ablate the fetal, okay, thyroid also. So this is non-pregnant. Usually which we continue, usually they stop it, different protocols. What we do 3 days, we stop it before, and 3 days after radioactive iodine, you stop antithyroid medication. Then you will resume it after 3 days. Then at 2 months, 6 weeks, depending in the clinic, you repeat thyroid function test and they continue on antithyroid medications. And at that time, depending TSH and free T4, you decide. You continue, you not continue. Usually the maximal efficacy of radioactive iodine 3 months. And usually majority of the patient will be ablated in 3 months. So at 3 months or more, usually we start this patient in 70% of the cases in thyroxine actually. We already stop we stop antithyroid medication, for example, carbimazole, and we start thyroxine. So the first initial month, you can do it at 1 month, at 2 months, and 3 months if you want. If you are so clever, if you cannot, you do it at least at 2 months.
Okay, I think we've got a final question here. I'm not sure if it's for you or Dr. Adnan. Is stem cell regenerative therapy considered a treatment for any thyroid problem in Saudi Arabia?
Sorry, what's the question again?
Someone's asking about stem cell regenerative therapy.
For what?
Is that considered an option for any thyroid problem in Saudi Arabia?
Adnan, I don't hear about it.
Yeah, I've never heard of it either.
But really, for me, I didn't. But still is promising in cardiology, in endocrinology, in hematology, still promising, but at least it is not at the clinical level.
Yes. How about you, Dr. Adnan? Have you heard of stem cell regenerative therapy?
No, I did not see any studies or any suggesting that, but thyroid diseases in children usually are treatable, and there is a treatment for it, very simple treatment, thyroxine treatment if it is hypothyroidism, and of course if it is Graves' disease, then there is also the other options available. I don't think we need to do stem cell therapy for those patients. Yeah.
Okay, thank you. Well, I guess there is no more questions. So I would like to thank Dr. Nasser Al-Jihani and Dr. Adnan Al-Sheikh for these excellent talks tonight. And have a good evening and good night, everyone. Thank you.
Thank you.